Hello, welcome to episode 8 of Fish TV. I'm Phil Wilkes, this is Dr Duncan Warning, and together we're the founders of 14 Fish. This is very exciting for us because this is our first ever episode with a guest. So in a minute we're going to show Duncan talking to Nigel Watson, who's the head of Wessex LMC's
Chief Executive. Dr Nigel Watson.
Dr Nigel Watson, sorry.
It was a great interview, and as we've said before with Fish TV, we try and keep it generic. Nigel's role is obviously very primary care focused, but I hope you'll agree it should be interesting for everyone. So it'd be great to hear what you think.
Great, let's take a look.
Where I'm here talking to Dr Nigel Watson, Chief Executive of Wessex LMCs, sits on the GPC. We used to work together, Nigel, but I've forgotten some of your roles shifted probably at the GPC since when I work.
I used to chair the commissioning subcommittee. Now I'm more involved in the new models of care and the Vanguard. So I do sit on the GPC as a backbench member, not as a subcommittee chairman.
Much more fun, I'd imagine.
Well, there are certain freedoms.
Fun and GPC, you don't always necessarily go to bed. So I guess I thought when knew you were coming to speak that one of the things that would be interesting to speak to you, and I've had the privilege of working at Wessex LMCs and with yourself for 3 years, so I've obviously had an insight. But I think I know I'd been a GP partner 5 years when I joined, and I probably didn't know that much about the LMC. Or what it involved. I sort of thought, well, that would be who you ring if we all fall out as a partnership, which is a role of the LMC, but obviously it's much more than that. I think now the role of the LMC is much more, people are much more aware of it, but wondered what are the sort of things that you enjoy most about your job, and what are the things you enjoy less about your job?
I enjoy the variety. No 2 days are the same. It is quite different from clinical practice. I spend 2 days a week in my surgery, which are very focused on patients and set time slots. Whereas, the LMC work, some of it's quite strategic. We spend quite a lot of time working about plans that will go on for many months and years in the future. But actually, there's quite a lot of similarity as well. A lot of it's about problem solving. We're presented with different issues that either individual GPs have, groups of GPs in a practice, or more and more some of the stuff that's going on across whole health economy. So, across the 3 counties we've got. So it's the looking at the big picture stuff and how does that relate to single GPs or practices. Also, the ability to be able to influence, because there is no doubt, certainly locally and in many parts of the country, the LMC is respected by many bodies. We have hospitals, the area teams, CCGs, who come to talk to us, ask opinions, ask questions, and we are able to have an influence. It doesn't mean we can totally dictate what's going to happen in the future, but you do feel when you look back, there are quite a lot of things that have happened that have been positive that we've played a part in, and that's very rewarding.
I have to say, I sort of was surprised at how rewarding I felt it, when you come from a general practice.
Not what you said at the interview, Duncan. So it wasn't until you got there you found it rewarding.
Well, you sort of didn't realise. I certainly did. As you say, there are lots of similarities, but you're doing, when you're a GP, you're sort of helping people in a quite direct way. Yeah. But actually you felt extremely productive. As you say, there's positive changes you could see being affected.
I think you asked another question, which is what are the negative things? I get, as you will remember when we work together, I'm slightly impatient. I want things to happen immediately. I find the barriers that exist in the NHS, I won't say unfathomable, but deeply frustrating. There are lots of things we could do to make things better for patients, for GPs, actually for the system. But the whole way of change is just so bureaucratic. So, I find that sometimes very frustrating, that change can be quite difficult, and implementing that change. Also, we seem to spend a lot of time doing things which have little value because the system makes us do it. I find that frustrating. I think it's also difficult when we represent about 3,000 GPs working in 500 practices, And when you come across difficult situations, some of the partners' disputes where people hit a period of adversity, so we support individual GPs and practices, and that can be quite difficult when you've got partnerships that are in dispute with each other and there seems to be no way forward. So when you can find a solution and help people, that's rewarding. When you can't, then that makes it more difficult.
How's it been in the office the last 3 years?
Well, it's been different since you've not been there. So it's calmer. There's less talk about gadgets and IT stuff, which has been a bit disappointing, but we found other things to fulfill our time. So, yeah, we've got a great team at the office, lots of variety in terms of personality, skills, from the people that support the LMC, the admin staff, the GPs and the other non-medical directors. There's a great team covering quite a wide area. And I think what has been quite interesting in the 10 years I've been there is actually how the complexity of what we do has changed. So if you look at things that are going on at the moment, there are loads of stuff going on with national strategies to do with transformation, to do with the new models of care, to do with how CCGs commission services. It's becoming increasingly complex, which on one level makes it interesting. On the other, with the current state of general practice, where recruitment and retention is a real problem, then we want solutions fast. We haven't got a huge amount of time to try and find better things to do, rather than just say, well, actually we can't recruit GPs, so what do we do?
If you touched on their recruitment, and one of the questions I was thinking of is if you, and I mean it's a hypothetical question, but say if you were 5 years younger and considering going into general practice, do you think you'd go into general practice at the stage?
Yeah, absolutely. I 5 years younger, I mean if I was 25 years younger, I've been a GP for 30 years. I still think being a GP is a fantastic job. It's very rewarding. I think there are difficulties, there are lots of things that need sorting out. But absolutely, I believe that if I went back to the start of my career, I would be a GP again, and I'd still do the job, I think, despite some of the challenges. I think going forward, if we can resolve a lot of the difficulties that we face, actually general practice will be the place where things happen. We cannot carry on relying on hospital-based care. One of the reasons we're in financial difficulty is, firstly, as a nation, we don't put enough money into the provision of publicly funded healthcare. But the second bit is, over the last 5 or 6 years, most of the new money's gone into hospitals. Well, the future is about delivering care in the community, and general practice needs to play a significant part in that. So some of the plans in the GP Forward View and in the new models of care focus on wrapping services around patients, putting stuff more in the community, putting GPs in the driving seat. So, there's a bit of me that wishes I was 10 or 15 years younger, because I think the next 10 or 15 years may be difficult because of the financial challenges, but will be really exciting in terms of what will happen in general practice.
And do you think, because it feels like there's more of a recognition, at least now, that has to be a part of the puzzle of the solution?
Yeah, absolutely. I think if you go back, even not that long ago when you were a GP, general practice felt that it was a second-class citizen, and it was treated like that by other parts of the health service. That hospitals didn't value GPs as much as they valued consultants. It has been interesting working in the LMC over the last year or so, how many of the hospitals are now coming to us talking about planning for the future and what can be done differently. So I think there needs to be parity of esteem between consultants and general practice, and I do think that's happening. When you look forward, part of the drive in these transformation plans is the role of general practice in that, because as far as I can see, if we don't get the community-based model, the out-of-hospital model led by GPs, who we know do 90% of the face-to-face contacts with patients, if that's not supported, expanded and developed, then the rest of the NHS has no chance of survival. It cannot carry on. If we grow the activity in secondary care in the rate that's been in the last 10 years, then by 2030, 2040, all of the resources will need to go into hospital, because as our population ages, as people get more long-term conditions, there is no way that will be coped with by a dwindling workforce that might appear in general practice. So it's in everybody's interest to make general practice a great place to work again, so that we can recruit and retain GPs, but also look at other people that can support general practice, whether that be extended scope practitioners in musculoskeletal care, pharmacists, or a whole host of other people who we're developing to be able to support GPs in their role.
Because that you've sort of touched on my next question, really, which was there's obviously there's some positives there about what, as you see the future of general practice in the NHS and general practice being a key part of that solution. I am no longer practicing as a GP, but obviously, as you know, my wife's a GP, and through this role still have contact with general practice. And there's always been sort of swings, hasn't there, of morale, and how do you think that there's a way, because morale seems to be at an all-time low in general practice at the moment, so how can we get those GPs, do you think, engaged to actually be able to take some of this forward? Because that's what that relies on, doesn't it?
It does. And then, in my 30 years, we go through 5-year cycles. So things are good and then they get progressively worse. And then suddenly the government comes up with a bit of extra stuff, which then makes GPs a bit happier again. And then we go for another 5 years and it's sort of, surplus and famine. The difference this time is that we've reached a place where I think we've not been before. And for some, there doesn't seem a future. And I think that's where, in a way, we've got to stop talking about the negative and talking about the disaster in general practice and how bad it is, to actually the good bits about general practice and what could be done to make it better. So again, the LMC is focused on what the solutions are. We all know what the problems are, but that also means looking at lots of different solutions. There isn't one thing that's going to change everything. So, for example, we need to encourage more people to come into medicine to be doctors. Of those that come in, we need a greater proportion to come into general practice. We need to change the way we're training people so that there is a much more community focus. So we don't get this sort of attitude that if you train, you become a hospital-based doctor, and if you can't do that, then second best is to go into the community. I think we've also got to change some of the concept of this is a hospital. A hospital is only bricks and mortar. Actually, some of the people that work in hospital need to work in the community and work with general practice. I think it's about the younger GPs in training to make sure that their training is focused on delivering care in the community, not doing specialist neonatal jobs in training, for example, to create different roles and different posts. Encourage younger GPs to join the profession. We've got a bigger proportion of them who are female. We've got a larger proportion who want to work part-time rather than full-time. Now that's all possible if we develop the structure to be able to deliver that. I think there's also a bit in the middle part of the career where people want to do portfolio work. So they'd like to be a GP 3 days a week, but actually do a couple of days a week doing other things. And we've got to create those opportunities. And rather than go into the hospital and become a diabetic associate specialist doctor, we'll actually have them in the community doing diabetes as a special interest, but actually supporting the work done in practices. And then when you get to the end of the career, after 30 years, some of my colleagues are counting the days till they retire. But many of them actually like being GPs or like seeing patients. So is there a way you can create roles, whether it's in urgent care, in long-term conditions, in frailty, and other things, where actually they do set work and you get rid of some of the things that actually become the drain and the thing that make people want to give up. Talking to GPs who've been around for some time, what is it about general practice today that's changed? And they will say that its workload is the primary thing and that the working day has become uncontrolled. So whereas before, I think most people like being busy, but it's gone beyond being busy to actually you feel out of control. Well, actually, if you can give a sense of that control back, and that's about looking at what the jobs and roles are, but also about taking out some of the stuff that really irritates GPs, which is, another form to fill. Somebody's decided they want you to do this or you want to do that. So it's a lot of the bureaucracy that exists in the system. Actually get the clinicians to be able to be freed up to do the stuff that they're skilled and valued at doing, the clinical work, not the 20 to 30% of the stuff that we end up chasing around the system. So, to come back to the beginning of your question is, I think things are beginning to get better. I think there's a long way to go. I think there are positive solutions. But we've got to encourage the younger generation to come and join us because it's their future that we're developing. If the current status of they all go to Australia or stay being locums and don't want to come and be employed doctors or partners, then we'll never change the system. We need to get them in there, and we need to provide valuable jobs, and we need to reflect what the profession is looking for. So the partnership model still exists and will exist for some time to come, but there are people who don't want the partnership model. They want an alternative. They want an employed model. So we've got to be able to develop those systems and actually get the workforce to deliver the care in whatever format that the workforce deems to be acceptable.
Fantastic. Well, thank you, Nigel. That's really, really useful and interesting. And we always, with Fish TV, try not to make it too specific to general practice or to nurses or to any health professionals. And obviously this is quite GP focused, but I'm sure is going to be of interest to everyone watching this. So thank you very much. And it was refreshing to, times are difficult. There's no point denying that, but actually to be positive and pragmatic about it is always refreshing. So would you perhaps come back and speak to us again in the future if we?
If you're nice to me, I might, Duncan. Perhaps we could talk about gadgets next time.
Yeah, or a fish mug, perhaps. You never know. You never know.
I'm not open to bribery.
Yeah. Yeah. Well, thank you very much. And,
thank you.
Thanks, Nigel.
If you have any comments on that interview or just on that format, any ideas you've got for guests, we'd love to hear from you.
Definitely. And, the same goes for questions. So we're always asking for questions, but it shows you, hopefully, that they don't have to be about medical education. We could then put these questions to future guests and if Nigel comes back. So please do feel free to send anything in.
And remember, you get a free 14 Fish mug.
Ooh.
If we use your question.
But Phil, if they did want to ask a question,
yes,
how might someone do that?
Well, you can contact us via the website, of course, and we're on all the social media channels. You can comment on this video on YouTube down in the comments. Follow us on Instagram. Tweet us at 14fish, and please don't forget to like us on Facebook.
Yes.
And then you'll be the first to know when we release new episodes, and keep up to date with all things 14 Fish.
Facebook.
It's great.
I must check it out.
Yeah, it's good actually. It's quite popular these days. Yeah.
Yes.
Yeah.
Think it'll catch on? Yeah.
Well, who knows?
Yeah.
Right, we'll see you next time. Bye-bye.
Thank you very much. B-roll, balance, go. Probably a whole conceptual new TV concept. I have to have the last tap.
You ready?